All my dear students. So let's start with a very short and crisp chapter, and that is lids. Let's understand the anatomy. We'll make diagrams here. So if this is the upper lid and this is the lower lid, this will become one canthus and this is there. Suppose this is medial canthus and this is your lateral canthus. What we will learn here is that the horizontal length of the lid, right? So the horizontal length of the lid is around 28 to 30 millimeters. And vertically, what is this gap called? Palpebral fissure. This palpebral fissure will be around 8 to 10 millimeters. When the horizontal length decreases, this is what you call, any decrease of this horizontal length is blepharophimosis. Blepharo is lids, phimosis means shortening. Now, lateral canthus is generally above the medial canthus. So, lateral canthus is normally 2 millimeters above the medial canthus. 2 mm above medial. When it is more than 2 millimeter, we will call it mongoloid slant. And if it is reverse, say medial is above the lateral, reverse means medial is above, medial canthus is above. Now what do you call it? Anti-mongoloid slant. So, a little bit idea of this you should have. What is the normal position of your two canthi? Okay, next to understand the basic structure of the lid, we will make an oversimplified diagram from my side. So, this is your tarsal plate. When you look at the lid, mainly it is made up of thick connective tissue which is tarsal. Now, this is your lid margin. The small strip is lid margin. This lid margin is divided by a line that is called gray line into two parts, that is anterior lid margin and posterior lid margin. Now, anterior lid margin, the eyelashes are arising, and posterior lid margin has openings of meibomian glands. And where are the meibomian glands? Meibomian glands are mainly present in the tarsal plate, right? So, this is your, you can say, meibomian glands are present in the tarsal plate. Just make it simple. So these are the meibomian. I told you, oversimplified diagram. Let's stick to that. This is in the tarsal plate. Got it? This much? So there is a difference. What is lid margin? What is lid? Right? This is the tarsal plate or the lid, and that one is your lid margin. Now this grey line is actually dividing all the layers of the lid, if you think of, into two lamella. So this grey line is dividing the lid into two lamella. One is anterior lamella and another is posterior lamella. Anterior lamella and posterior lamella. Now anterior lamella, what are the structures? Think with me. Anteriorly, first will be skin. Then comes your subcutaneous tissue, and then the next muscle which is superficial, this is your orbicularis oculi. All these will come as in the anterior lamella. And posterior lamella, now think further, first thing is tarsal plate. After that, what you see is the tarsal plate. And what are the muscles attached to the tarsal plate? What are the retractors? So, we will first mention here LPS and molars. Or it could be lower lid retractors if I talk about lower lid. So, either this or this. Right? And what next? Conjunctiva, right? Tarsal plate along with this meibomian glands, don't forget, and this is your conjunctiva. Last, right? Okay, where is the orbital septum then? Corresponding to the grey line, if you go back from this lid margin upward, corresponding to that location is orbital septum. We have made this diagram in the orbit, and let's make it again to understand. If this is the tarsal plate, right? This was your lid margin. Okay? Okay. Here again, lower lid margin, lower lid I'm making for you. Okay? Simple now? Okay. So this is your supraorbital margin and this is the infraorbital, the bone, right? Between the two, I have taught you this, that where the tarsal plate is ending and this is the bone, there is a gap which is filled by a thin connective tissue, and this thin connective tissue is what is called orbital septum. So this is the location of orbital septum if I talk in the upper lid, and this is the location when I talk in the lower lid. Got it? So this is the orbital septum, and if I am going to dissect, it is corresponding to the grey line. I hope now you got it. I am going to show you the slide as well, but first we'll make all these simplified diagrams. So this was about your basic structure. Now we talk about one by one. First is, if you talk about the clinical significance, let's start with skin. Now skin, we should all know clinical application, what you have to keep in mind. It is very, of course, the subcutaneous tissue is very loose, and the skin above, normally if it is in excess, that condition of excessive skin is what is called dermatochalasia, and it can become a cause of, it may mimic ptosis, okay? It may cause, because of the hanging of so much of the skin, there can be some drooping of the lid, but this is not actual ptosis, it has nothing to do with the muscles. So we call it, it is a cause of pseudotosis. Okay, so this is a cause of pseudotosis. And what is the treatment here? How will you manage this excessive skin? We will answer blepharoplasty. Subcutaneous tissue. Subcutaneous tissue, we will note one point here. This subcutaneous space is very loose, and therefore whatever swelling is around the eyes, you see it's too much. Even an insect bite, it swells like anything. It looks very dangerous, though it is not. Why? Because of this loose connective tissue. This is the plane where blood and this is the plane where your blood or edema, this all collects. Okay? So keep this in mind. And because it is too loose, it is excessive. Third was orbicularis oculi. Now orbicularis oculi, you know, is a muscle. First of all, it closes your eyes. So it is mainly for blepharospasm or closure of the lids. Or closure, you will say. Right? It is supplied by seventh nerve. We all know that. So any facial nerve palsy, this will be affected. Now this orbicularis oculi mainly has two parts. One is over the lids, one is orbital part. So it can have a palpebral part and it has an orbital part. Right? So when you say palpebral and orbital, orbital is mainly responsible for forceful closure. This is mainly responsible for, so forcefully aankh meech lena. So you're forcefully closing the eyes, that is due to your orbital part of your orbicularis oculi. So this is your forceful closure. If you are asked to open the eyes, you're not opening it, you're closing it. Palpebral, it can be in front of the tarsal and can be in front of the septum. So when it is in front of the tarsal, we call it pretarsal part of the orbicularis oculi, and in front of septum is preseptal part. Right? Now preseptal part is responsible for voluntary blinking. Like I am blinking like this voluntarily. So this is, which muscle is responsible? It is preseptal. Okay? So we will learn this together. This is for voluntary blinking. Whereas when we talk about pretarsal part, pretarsal in front of the tarsal plate. Pretarsal part is, of course, first important point here is it is your involuntary blinking. So when you are not even aware, you know, involuntary blinking is a normal phenomenon. What is the rate of blinking? What is the normal frequency of blinking? 12 to 20 per minute. So much times per minute. That every 3 to 5 seconds we would blink. This is the involuntary blinking. Apart from that, the pretarsal muscle is also attached to the lacrimal sac, at the anterior and posterior lacrimal crest. Why? Helps in lacrimal pump. Okay, so we all know that lacrimal sac pumps the tear down. So this lacrimal pump is mainly carried out by pretarsal part of the orbicularis oculi. Is it clear? Okay. This is called Horner's muscle. Sometimes we call it Horner's muscle. Be familiar with this. And then another name for another muscle is, what is a ryolan muscle, is also a part of pretarsal part of orbicularis. Ryolan muscle is mainly responsible for the formation of gray line. Now this is a little extra information. If you don't want to remember, it's okay. They won't ask you. Right? That was your anatomy. And what is the inability to close the eye known as? We all know, we call it leg of Thalmos. When the eye cannot close, we call it leg of Thalmos. Inability to close the eye. Right? This will happen in facial palsy, that is 7th nerve palsy. It's a feature of 7th nerve palsy which supplies the orbicularis oculi. Now this is, what is the main issue? If the eye is not closing, cornea is getting exposed, and that is affecting the cornea, which is leading to exposure keratopathy. It can be cause of blindness if we don't take care of it. Right? So due to the facial nerve palsy, this problem that is happening, this whole condition is called neuroparalytic keratitis. We call it neuroparalytic keratitis. And do you all remember, we talked in cornea, what is your neurotrophic keratitis? That was due to 5th nerve, right? Where the health of the corneal epithelium is compromised due to no sensory supply. Okay. So that was about your leg of Thalmos. And how do you manage leg of Thalmos? Either we can do some patching, isn't it? How do you manage leg of Thalmos? We can go for some patching. So there are the new modalities. We have gold weights that can be put to droop the lid so that it closes. Otherwise, we have to just stitch the two lids together. What we call that? Tarsorrhaphy, right? Or tarsorrhaphy. Okay. We come now to the posterior lamella. First is your tarsal plate. If you look at the tarsal plate, so this tarsal plate, the width at the upper lid is around 8 to 10 millimeters, right? Whereas for the lower lid, it is little shorter. Can you see the vertical length is less? So this you will learn it as, it is 4, almost half, 4 millimeter. So this is the vertical height we are talking about for the tarsal plate. Then we talk about that if these are the two lids, I mentioned earlier also or not? Okay, so these are the two tarsal plates. They will join at the medial and lateral canthal. Medially, it actually, so these are Y-shaped with 3 limbs, the medial canthal and the lateral canthal tendon. So this is your lateral canthal tendon. Right. So this lateral canthal tendon, this is again a part of orbicularis oculi. And this is medially, and it is attached to, one more name here please, Whitnall tubercle. This is attached to Whitnall tubercle. I'll talk about Whitnall's ligament shortly. Now, what are the muscles attached to this tarsal plate? Upper border, it is the molars, and the lower border is your LPS. Let's talk about the lid retractors. So the next heading is lid retractors. So talking about the lid retractors, let us divide it into what are the retractors in the upper lid and what are the retractors in the lower lid. Talking about the upper lid retractors, we all know first is LPS, levator palpebral superioris. This levator palpebral superioris is supplied by, everybody knows, we have discussed it in neurophtha also. This is third nerve, right? And second is your Muller's muscle. What is the other name of Muller's? It is also called superior tarsal muscle. So Muller's or superior tarsal muscle, this is supplied by sympathetic supply. It is supplied by sympathetic supply. Right? So, what about the now lower lid retractors? Lower lid retractors, first is your capsulopalpebral fascia, CPF. Note it down, it is capsulopalpebral fascia. So capsulopalpebral fascia is actually coming from the sheath of the inferior rectus tendon. So this is coming from the inferior rectus muscle, I mean. Okay. So from the inferior rectus fascia, we will say it arises from inferior rectus fascia. What is the next retractor here? Second you will say is again corresponding to the superior tarsal. This time we will say inferior tarsal muscle. So we are saying inferior tarsal muscle. And we talked about orbital septum, isn't it? So orbital septum arises from periorbital fascia. Okay. So this is mainly periorbital fascia from the periosteum. It rises from, write down, periorbital fascia from periosteum. And the same periorbital fascia is also giving rise to annulus of Zinn. If you remember, we learnt it. It is crossing the supraorbital fissure. So we go back to this clinical slides. So look at this one. First of all, in this diagram, what do you see? First of all, this one. We are revising the anatomy. We have discussed it. You have cleared your basics. Now you will appreciate these slides. So if you look at this one, this is your orbicularis oculi. This is the direction of orbicularis oculi. Right? These are the two tarsal plate and the gap. This is called palpebral fissure. Right? This is the lacrimal sac. Part of the orbicularis will form the Horner's muscle. Then this is all orbital fat we are talking about at the two positions, right? And this is your levator palpebral superioris supplied by third nerve. So this one is your LPS muscle. Okay? And of course then it is showing you the tendon of superior oblique. So just remember this. Okay, so that was the fat we were mentioning here. Next we talk about is this diagram. So if you look here, if you think with me, start thinking with me. Gray line was dividing the lid into anterior and posterior lamella, right? What was in the anterior lamella? First is skin. So this is the skin. Then what was it? Subcutaneous. So this is it. Then what do you see? Orbicularis. So these are the muscles shown here. These are orbicularis oculi. This is the orbital portion. And when you come down, this becomes your palpebral portion of orbicularis oculi. So this is a section of the lid which is we are seeing it. Okay, and of course this is the gray line location which is dividing into anterior and posterior lamella. So this becomes the gray line. These are the lashes, eyelashes from the anterior part of the lid margin, and these eyelashes, please this add it, we haven't written, you can add here. It has sebaceous glands which is gland of Zeiss. At the base of the follicles we have gland of Zeiss and there is also gland of Moll. Okay, now this gland of Moll is sweat gland, modified sweat gland, and Zeiss is a sebaceous gland. So this is a modified sweat gland. Remember this. Okay, have you drawn it? Skin, subcutaneous, anteriorly you can make this lid margin, the eyelashes, and finally we talk about orbicularis oculi portion, and these are the sweat gland. This is going to extend gray line corresponding to this one. This is what? This was the gray line and this corresponds later to orbital septum. Now we will come posteriorly. So this is anterior, right? And this becomes your posterior lamella. So in the posterior part, first thing is what? Posterior lid margin, you have opening of meibomian gland. So this is the meibomian gland here. This is the tarsal plate, isn't it? Inside the tarsal is the meibomian gland. Simple. Now we talk about what are the muscles attached. Upper border, it is your arising from the LPS is your Muller's, this one, and lower border pe out here till here is your levator palpebral superioris. Right? We are showing you the upper lid here. If we are, so this is the posterior lamella and these are the important things you have to keep in mind. Once this is clear, now even this one will be appreciated. This is what it is showing you. This is the tarsal plate. These are the eyelashes with your sebaceous gland of Zeiss. So from the posterior lamella of this is the LPS, okay, and from its posterior lamella arises your Muller's, which is going to attach on the superior border of the tarsus, right? So this is your eye now, as you can see here. So this will become the conjunctiva. Innermost part is conjunctiva here, right? Yes, so this pink will be your orbicularis oculi, and this is the orbital septum. So we are actually looking at the same diagram again, just so that we are absolutely clear. So once we are clear with this basic information, a little bit more about the LPS muscle needs to be mentioned. So LPS arises from lesser wing of sphenoid above the optic foramen. So this green one is your LPS. Now think and listen to me. The LPS which is arising from the apex of the orbit from the lesser wing of sphenoid, right? Lesser wing is part of the roof. From there it is moving in front. When it is going to reach anteriorly, it will stop at Wittnau's ligament. And here it will change its direction and go vertical. From horizontal, it becomes vertical to insert on the tarsal plate. So this change of direction is happening where? On the Wittnau's ligament. Okay, so let's appreciate this diagram. This is the muscle, LPS muscle, this one. This LPS muscle, when it is at the Wittnau's ligament, it is becoming vertical and it is becoming an aponeurosis. So after Wittnau's ligament, it is not the muscle, it is the aponeurosis. Whereas it is inserting. Now there are many insertions of the LPS. They ask you in detail in a PG level as well. But what we will learn in a crisp manner, first listen to me how to learn. Lower border of tarsus, the two canthi, and don't forget the skin, because the lid crease is formed due to the attachment of LPS to the skin. Okay? This was one of the quickest to explain. Okay, and lower it is also showing you the CPF, that is capsulopalpebral fascia, which is the lower lid retractors. Right? So these are the two tendons they are showing, lateral and medial canthals. So this aponeurosis is attached at the two canthi also, to the skin also, and to the lower border of tarsus also. Can we see it here now? What are the insertions of LPS? I don't want you to mug it up or something, just keep reading it, you will understand. So it is at the lower border of tarsus, lateral or vital tubercle lateral side, then medial horn, then skin, lid crease and conjunctival fornix, and few more insertions can be at the orbicularis oculi. And of course, we know this, that the posterior lamina is giving rise to Mueller's muscle. Okay? So this is again very quick information. It is starting from the orbital apex, moving horizontally at the Wittnau's ligament, it becomes aponeurosis and becomes vertical. And then vertically it is being attached to the different insertions will be lateral, medial, lower border of tarsus and skin, orbicularis oculi and conjunctival fornix. Now I think you have learnt with me. So these things are important. Once we are very, very clear about that, then we can move further. What are we seeing now? We are seeing orbicularis oculi. We have already learnt the detail about it. So this orbicularis oculi at the pre-tarsal is this one above the tarsal plate. This becomes your pre-septal above the septum, and the rest here it will become the orbital portion. We have already learnt about this. What is the involuntary blinking by pretarsal and voluntary by preseptal. Leg of Thermos we just talked about. So this is a case of leg of Thermos. Inability to close the eye. Okay, next we will give the heading ptosis. All of you. Let's talk about ptosis. So what is ptosis? Everybody knows. So it is not ptosis. Some people even call it this. So this is ptosis I am talking about. So P is silent here. So when you say ptosis, it is drooping of the eyelid. Drooping of the upper lid is ptosis, we all know. But do you also know that there can be ptosis of lower lid also? I mentioned in the Neuro-Ophtha chapter how the lower lid, if the sympathetic is gone, the inferior tarsal muscle is also supplied with the same, which will be affected, and the lower lid is going to rest at the higher level. Okay, so that becomes a lower lid ptosis. But anyway, don't confuse. That's why I'm not writing it. This was just an information here. Whenever we mention the word ptosis, we mean drooping of upper lid. Okay? Now, what is the normal position of your lid? So you all should know this, that upper lid covers 2 mm of the limbus. It is covering 1/6 of the cornea, and lower lid just touches the limbus. Okay? So when it is going below its level, when the lid is going below its level, you are calling what? Ptosis. And when it goes above the level, above its normal level, what do we call that? Retraction. It is not proptosis, okay? Very common mistake again, people answer like this. So it is lid retraction. Okay? Okay. So let's start writing. So drooping of the lid is ptosis. Drooping of lid is ptosis. We are talking about upper lid. Now this ptosis, or which is drooping of the lid, can be classified as, what is the way of classifying this? You can classify it as congenital or acquired. When you talk about the acquired ptosis, acquired can be due to nerve problem, neurogenic, muscle problem, myogenic, then aponeurotic problem, aponeurotic, or lastly mechanical. Okay, so I again repeat. So classification, it can be congenital and acquired can be neurogenic, myogenic muscle problem, aponeurotic and mechanical. The last one I have written is, I'll write here, mechanical. Okay. Now, talking about congenital, the congenital ptosis can either be a simple congenital or it could be complicated. When you say simple congenital, it means there is only one feature and that is ptosis. What is complicated? It could be, mainly what you have to learn here is blepharophimosis syndrome. We all know syndrome means many features. So, blepharophimosis syndrome. Another one that you have to know is Marcus-Gunn-Jaw-Winking phenomenon. We are just discussing the classification here. Marcus-Gunn-Jaw-Winking phenomenon. And what is third? Double elevator palsy. Third is your double elevator palsy. So we'll be discussing one by one each of them. Right? So let's start with your acquired ptosis. So first we say acquired ptosis. First is, what is neurogenic? Very simple, common sense. When you're talking about the upper lid, what is the supply of LPS is third nerve, supply of Muller's is sympathetic. So what can be the cause of neurogenic? One is your third nerve palsy, right? Third nerve palsy, and second you will know is, learn is Horner's syndrome. Horner's syndrome. Next we talk about is myogenic ptosis. Acquired myogenic ptosis. Okay, one more question. Among all these four types of acquired, which is most common? Most common you will answer is aponeurotic. This was your exam question, put a Q. Right? Aponeurotic. We also call it generally idiopathic, but just remember most common is aponeurotic. Okay, coming back to myogenic means muscle problem, and we are discussing the acquired ptosis. So what can be the acquired muscle problems we are talking about? Of course, we are talking about myasthenia gravis, right? We are talking about the variant of myasthenia, that is Lambert-Eaton syndrome. Then we are talking about is, there's one condition called PEO or CPEO, that is chronic progressive external ophthalmoplegia. So it is chronic progressive external ophthalmoplegia, which involves the extraocular muscles and ophthalmoplegia. And we can also include in this list myotonic dystrophy. We can talk about myotonic dystrophy here. Okay, so these can be some causes or myogenic causes of ptosis. Now, what needs a little more mention is myasthenia gravis. Let's talk about myasthenia gravis. You all know myasthenia gravis is a, you know, and you have learned it in detail in your medicine. So, what is actually happening? What is this condition? Main problem is, what is the pathogenesis? Antibodies towards the acetylcholine receptors. If you talk about the NM junction, if this is the nerve end and this is the muscle end, isn't it? There are the receptors out here. So the nerve end is secreting your acetylcholine, and this acetylcholine should act on these receptors, isn't it? And therefore the muscle contracts and a potential is generated. Now what happens in myasthenia gravis? There is antibodies against these receptors. Therefore, the potential that is generated is very minimal. The muscle contraction will not be proper, right? Because acetylcholine is now not enough because of the antibodies against the receptors. Have a look at this diagram. It will be very clear how the axon, this is the nerve end, acetylcholine which is released here acting on the receptor, and this is the potential created. But when there are antibodies against the receptors, so this is the end potential becomes flat. Right? So this is what is myasthenia gravis. So we all know it affects mainly the skeletal muscles. And if I talk about the ocular feature, isn't it? So if I talk about the ocular feature, it is mainly affecting the LPS and the extraocular muscles are affected. It will affect all striated, even orbicularis oculi. So if because LPS and extraocular muscles are affected, then what will be the presenting feature of the patient? I am talking mainly ocular. So a presenting feature would be ptosis, and second would be your diplopia. The first extraocular muscle to be affected, first muscle to be affected is your medial rectus. So it starts with ptosis and diplopia. Okay? And what more you have to mention here, it is going to worsen at the end of the day, isn't it? For ptosis, if I talk about, so please note it down here. So let's note this down, that it is worst on prolonged upgaze and worst at the end of the day. We are talking about ptosis. Worst on prolonged upgaze because LPS is working too much, so slowly acetylcholine is not enough and ptosis will set in more. So similarly worst at the end of the day. Next we talk about few tests. Give the heading tests for myasthenia gravis. So some tests that I can do to know that okay, this is a case of myasthenia gravis. Very important first is Cogan twitch test. What is Cogan twitch test? You ask the patient to keep looking down for some time. Then after around 30 seconds or so, 30 to 50 seconds, you ask him to look up, and in the primary gaze, you will see this twitching of the upper lid, right? So you relax the LPS too much, and later when it's working, there's twitching of the upper lid, and this is what is called Cogan twitch sign. It's a very definitive sign to diagnose myasthenia gravis. Okay, so when you talk about the tests, first was Cogan twitch sign, and we will put a Q here. And second you are going to learn here is fatigability test. Fatigability test means that you ask the patient to keep looking up, up, up. Naturally the LPS is going to get fatigued and you will see the drooping. Okay. Third is eye peak sign. What is eye peak sign? You ask the patient to close his eyes continuously for some time. Again the same 30 to 50. What happens? Orbicularis now gets starting tired and there is a peaking of the little opening of the eyes. That is what is called eye peak sign. You'll remember? Yeah. What about some lab investigations? These are if you talk about the lab investigations, we all know, we all have learned about Tensilon test. So Tensilon test can be done. What is Tensilon exactly? So this is an anticholinesterase, isn't it? So it is actually blocking the enzyme which is metabolizing acetylcholine, so that acetylcholine is staying for a longer time at the NM junction and acting, right? This is what it means. So Tensilon test, what do? You are using 1 milligram of neostigmine, isn't it? So this one you know also, a very quick mention here. This I can give intramuscular or I can go for 10 milligrams edrophonium. This one is given IV. What do you see after this? Because it's an anticholinesterase activity, therefore there will be improvement, right? So ptosis will improve. So there will be improvement of ptosis. Improvement of ptosis. And the same anticholinesterase activity can also be achieved by IcePAC test. So this also acts as anticholinesterase, and therefore what happens? The ptosis improves. Right? So this was a quick mention of few tests. They have asked you about Cogan twitch, so we have to know a few things around it. That was your myogenic ptosis. What will be the next type of ptosis? Aponeurotic. Aponeurotic ptosis means, I told you this is most common, you will learn, and this is mainly due to dehiscence of aponeurosis. Dehiscence of aponeurosis. So when I say dehiscence of aponeurosis, this can be either postoperative or it can be involutional. Postoperative or in old age, that is involutional. That is old age. Okay, what is very, very important, because of the dehiscence, what you are getting is a high lid crease. The lid crease, I told you, is due to attachment of the LPS to the skin. So now due to dehiscence, it moves up. This is important. Okay, have a look. This is a high lid crease that you can see in aponeurotic ptosis. Right? This is a ptotic eye with high lid crease. Actually, there are too many lines on this because of his age. Maybe it's confusing, but it's at the higher level. Just remember this. Okay, what comes next? Next comes your mechanical. Mechanical ptosis means due to some swelling, something, the lid is drooping down. So, listen to me. Either there is a pushing mechanism because of which the lid is drooping down, or it could also be pulling mechanism by the conjunctiva. Due to scarring of the conjunctiva, there is ptosis. So there are two methods. This one is showing you the pushing mechanism where any tumor, chalazion, neurofibroma, it is causing ptosis. Second we will learn is pulling mechanism where it is happening due to any cause of conjunctival secretization. Okay, conjunctival secretization. So what are the causes of scarring of conjunctiva? We have learnt in conjunctiva chapter also, like trachoma, all types of burns. We have talked about Stevens-Johnson syndrome. We have talked about cicatricial pemphigoid. Remember? So we have to remember all this. This is about your mechanical ptosis. Now give the heading congenital. When I say simple, it means there is only one feature, and that is ptosis. So when you talk about simple, give the heading, I am writing here only simple congenital ptosis. In this case, it is showing you a bilateral ptosis which is congenital. What is very, very important is absent lid crease. Now think yourself, LPS in congenital ptosis is not formed properly. So this attachment with the skin is not good. You don't get any crease. So this is an important exam question as well. So absent lid crease, you have to remember. What is the second feature is, suppose it's a unilateral ptosis. This one is also important Q. Please put a Q here. Lid lag on ptotic side. That is a sign of congenital ptosis. What is lid lag? So normally when you're looking from up to down, let's understand this. When we look from up to down, what happens? My lid is following my eyeball. But if suppose the eyeball goes up and the lid is still behind, that is called lid lag. Now understand this. Suppose this is a case of congenital ptosis. So this is a normal lid and this is the ptotic lid. You ask the patient to look up, this lid goes up, this cannot go up. But little bit it moves and stays like this only. When you are asking this patient to look down, now this goes down, this can't even go down properly. There's a lid lag. So that's what we are saying, lid lag on the ptotic side. And why is this happening? This is important. LPS is not formed properly, therefore there is not only defective contraction but also defective relaxation of LPS. Okay, so because LPS is not formed properly, there will be defective relaxation as well, and because of that there is lid lag on ptotic side. Okay, and of course it can also be associated with, now what is that called is double elevator. So next heading is double elevator palsy is nothing but LPS involvement with superior rectus involvement. LPS palsy with superior rectus palsy. So you are getting ptosis, and along with that there will be on that side the level of the eye is lower than the normal side. It is hypotropia. So tropia is squint, hypo means it's below. Because superior rectus is primarily a elevator, isn't it? Yeah. And what is the third condition we have to learn is blepharophimosis syndrome. So when you say blepharophimosis syndrome, what are the features? Syndrome means many features. So let's talk about blepharophimosis. First write down, it's a genetic disease. Okay. So the gene responsible is FOXL2 gene. Right? Autosomal dominant. Now coming to the clinical features, how the child is born. First is shorter horizontal length, that is blepharophimosis. I talked about this initially. Second, there will be ptosis. This is also clear what is ptosis. Third, there will be congenital ectropion of lower lid. So lower lid is turning outward. Ectropion of lower lid. What is ectropion? Outward turning of the lid. What is number 4? Fourth you will learn here is telecanthus. Now what is telecanthus? All of you? Far apart medial canthus because of excessive soft tissue. That is called telecanthus. When the medial canthal ligament is long. Let's elaborate here before coming to the next feature. Suppose, let's put it in the box. This is important also. We'll put a Q here. Far apart medial canthus. We use two terms for this. One is your telecanthus. Okay. Far apart medial canthus. One is your telecanthus. And another term is hypertellurism. So what they have asked you in your exam is the difference between the two. Let's understand before writing. When the medial canthal ligament is long, there is soft tissue problem. This is telecanthus, which means the interpupillary distance from the center of one pupil and the other. This is normal. But imagine what happens if it's a bony problem. The two medial wall are far apart. So the broad nasal bridge and far apart medial wall. This time what will happen? The interpupillary distance is increased. So this is what is very important to know. Telecanthus is a soft tissue problem, whereas this is a bony problem. And therefore in telecanthus interpupillary distance is normal, whereas in hypertellurism interpupillary distance is more. It is increased. Right? This is your exam question. What are you getting in blepharophimosis syndrome? We are getting telecanthus. Okay, we next talk about after this is the next feature of this condition is epicanthus inversus. Now what is epicanthus? You all know what is, we will write it, just listen. Extra, so you see Japanese, Chinese people have small eyes. Why? Because there is an extra fold of skin on their medial canthus. Right? So many small children also have that, it looks like there's an epicanthus there. What is important to understand, this always arises from the upper lid. But in this syndrome, the extra fold is arising from lower lid. And therefore we call it inversus. Got it? Likho. Write down all of you. Extra fold of skin on medial canthus. This is what is epicanthus. When it arises from lower lid, we will call it inversus. So this is what you are getting. So let's have a look. What about blepharophimosis syndrome? So this FOXL gene is on chromosome number 3. I don't think they will ask you this. They generally ask you the features. Okay, before I move further, yes, this point reminds me something. In every congenital case of ptosis, if the visual axis is being covered, you understand, it means fovea will not be formed properly and you can get amblyopia. So we have to be very, very careful, and our congenital ptosis should be very urgently treated. Correct? Okay. So these are the features. See, in blepharophimosis, this horizontal length is less. This is blepharophimosis. This it is showing you the ptosis. And here it is showing you epicanthus inversus. This is your epicanthus inversus from the lower lid. Right? So, okay? So this was about your different types of ptosis. We next talk about measurements. So what is the normal position of the upper lid? It is covering 2 mm of the cornea. Lower lid just touches the limbus. So this is the normal position. Now, when I am showing the light, this light reflex is shining here. Right? So the distance of the margin of the lid till the light reflects, this is what is called MRD1. What is MRD? Marginal reflex distance. And the distance between this reflex and lower is MRD2. Now what you have to understand, once you know this, how do I decide the amount of ptosis? If it is a unilateral case, I am just going to compare with the other eye. So we can decide the amount of ptosis. Right? We can decide the amount of ptosis First is difference of palpebral fissure, right? So if palpebral fissure height is one thing I can look for. Palpebral fissure height, I will see what is in the normal minus what is in the ptotic eye, and this will give me the amount of ptosis. What second I can do? I can take the difference of MRD1. MRD1 again normal minus ptotic eye can be looked at. But what if both eyes are drooped? If both eyes are involved, you have to see the amount of droop. You already know the normal position of the lid. So, depending on the amount of droop, when I say amount of droop, normal 2 millimeter is normal. So, when I am saying droop, here, suppose the lid position is here now. So, this still here it was normal. So, amount of droop is only another suppose 2 millimeter, or it can be further. So, what you have to understand, from the limbus, upper limbus, this distance is how much? It becomes 4. But droop is only 2 because initial 2 is normal. This is what I want to convey to. Okay? So, we are talking about amount of droop. Now, you understand? Normal say further in addition how much it is? More downwards. This is what we mean by amount of droop. So, depending on the amount of droop, we can actually grade ptosis as mild, moderate and severe. Okay. So, mild means only 2 millimeter droop is mild. Then 3 millimeter droop. 3 millimeter means it's 5 millimeter from the upper limbus. 5 millimeter from upper limbus, isn't it? So, this is moderate, and severe is 4 millimeter droop. Right. So, this is how we are grading ptosis. Okay. Now, we talk about, once we know this, what is the treatment of ptosis? If I talk about neurogenic, any nerve will take time to come back, So, suppose there is a palsy and we want to wait for some time, for 5-6 months for it to return, revert back. Till that time, what we can use is crutch glasses. Just to buy time, just for that time we are doing. It's not a definitive treatment, right? So, these are the crutch glasses. It is going to support the ptotic lid like this, so that for some time the patient is not in a problem. Apart from that, of course, the next option apart from that is nothing but surgery, isn't it? Okay, let's discuss here. Any muscle surgery, what is the principle? It's the same, whether I'm talking for the squint or for the ptosis. What is that? I have explained you earlier also that if this muscle, if this is the eyeball and this is the muscle attached, I'm giving an example like this for extraocular muscle. So, if the action of this muscle is less, I cut and stitch it. The fiber length decreases, action improves. What is that called? Resection. But suppose it is too much of action, I don't want this much action, I just push its attachment backwards. So, going backwards is what is recession. Just like economic recession, this is muscle recession. Got it? So, this applies everywhere, even for the ptosis. So, I think we can understand this one for all and put it in the box. For any muscle surgery, in underacting muscle, we go for resection. And if the muscle is overacting, we go for recession. Okay? So, in overacting muscle, we do recession. In underacting, we do resection. What is happening in ptosis? Underaction, overaction. Underaction of retractors. Therefore, in ptosis, we can go for resection. Which muscle I should resect? So, what do I have in my hand? There are 2 retractors. So, either I cut the LPS and stitch it, or I cut the molars. What is the limitation of molars? Molar has only 2 millimeter of action. So, only a mild ptosis can be improved by molar muscle resection. Okay. So, if LPS I resect or molars, sometimes what happens when LPS is not formed properly, there is no proper action of LPS. So, what is the use of cutting and stitching a dead thing? It should have some minimum action. The muscle should have some minimum action so that when you are actually stitching it and resecting and cutting it, it should improve. So, LPS action is very important to first check. Suppose the action is not enough. and Muller's is also of no use. Then what I can do? Do I have any option? Yes, I can take the help of frontalis. How will the frontalis help me? Only when I connect the lid to it. So connecting the upper lid to frontalis is what is called sling operation. Okay. So now we say that in surgery of ptosis, there are three modalities I can follow. Either I go for LPS resection, or I go for Muller's resection, and or third I can do is sling operation. Now when I say LPS resection, I first have to check the action of LPS. How to check the action? For that, we go and measure the upper lid excursion. This is called Burke's method. So we are measuring the upper lid excursion. What is upper lid excursion? You ask the patient to look as much down as possible, block his frontalis, ask him to look as much up. So distance from his lowest mode to the uppermost position is what is called lid excursion. Got it? So this upper lid excursion, normally it is considered more than equal to 12 is considered normal. Some have 15, 16, it is good, no. But, and second value, I am not giving all the grading to mug up, I am just saying anything above 12 and more than 12 is okay. But of course, it can be less also. When should I not do resection is when it is as less than 5 mm. So the cutoff is if it is less than 5 mm, the upper lid excursion is less than 5 mm, don't do LPS resection. It is of no use. That means I need minimum 5 mm action for the LPS resection to be successful. Got it? Some books say 4, some say 5. Let's take 5. Now, next thing they will ask you, they have asked you the name of the surgery. So this LPS resection can be done either I start from the skin root or I start from the conjunctival root. If I start from the skin root, I call it Ever-Bush operation. You have to know the name of the surgery, Ever-Bush operation. And if I start from the conjunctival root, we call it Blaskowitz operation. So now we are calling it Blaskowitz operation. Now coming to next modality. What is that? Muller's resection. This I told you you will do when there is mild ptosis and there is good levator function. You feel there is no problem of levator function. In that case, and therefore main indication is Horner's syndrome. So in that case, I am going to do the Muller resection, which is called Fasanella-Servet operation. Nice name. I like the name. It's very musical. Fasanella-Servet operation. So what is Fasanella-Servet here? We are reverting the lid. Cutting a strip of, Muller's tarsal plate and your conjunctiva. This is what is, I'll just show you the slide. This is your Fasanella-Servet operation. Okay, we come to the third modality is sling operation. What do you do in the sling? I told you, write it down. You join the upper lid with frontalis muscle. Upper lid with frontalis muscle. Now what material I am going to use is the exam question. What is ideal? I can use silicone. Earlier Prolene was also used. But the choice of material, exam question, choice of material we are going to answer is fascia lata. We use fascia lata. Right? So that was about your sling operation and the third type of congenital ptosis. Let me explain you that also. So what is Marcus Gunn? That's the name of a scientist. So when you say jaw winking, what is happening here? Aberrant connection is there between the LPS and lateral pterygoid. So suppose again, let's take an example. This is a normal lid, this is the ptotic lid. I ask the patient to look up, this lid goes up, this is not able to go. But the same patient, when he moves his jaw, the lid goes up. So it becomes a jaw winking. Okay? So this is what is jaw winking phenomenon. You can write it there in the types of ptosis. I am writing here. So Marcus Gunn jaw winking phenomenon is what? Marcus-Gunn-Jaw-Winking phenomenon means there is an aberrant, so it's a type of congenital ptosis where there is an aberrant connection between LPS, which is third nerve, and lateral pterygoid muscle. This is your fifth nerve. Right? Okay. So how will you treat this one? Because you want to get rid of that aberrant connection. Na? So in this one, what you do is you are going to disinsert. We go for disinsertion of LPS. Along with that, I do a sling operation. Right? And sling you already know. So sling is mainly done in when the LPS function is not of any use. It is less than 5. So it is mainly done in severe ptosis. Just remember this. So it comes under severe ptosis. We do mild, moderate, severe. So severe ptosis, we have to do sling operation. LPS, and this one I told you the condition Fasanella cervate. Mild ptosis with good levator function. Right? For LPS resection is generally done for moderate ptosis. It is done for moderate ptosis. Okay, so let's have a look at these slides. So this is a Fasanella cervate. As I said, we are going to just excise the upper border of tarsus, lower border of molars and overlying conjunctiva by inverting the lid like this. Right? Now this one is your LPS resection. Right? At least 5 mm action should be there. Right? Severe ptosis, it should not be done. And this is the sling operation. We also call it frontalis bro suspension. So this sling operation of frontalis bro suspension is generally done for severe ptosis, right? And of course Marcus-Gunn-Jaw-Winking we have talked about. So this is how we are connecting the upper lid with the frontalis muscle. We call it Fox pentagon. Okay, yes, another entity, what is pseudotosis? So when the cause is actually not due to any problem in the retractors, it looks like the eye's lid is drooping, but it is not. That is what is pseudotosis. What can be the cause of pseudotosis where there is no problem in the lid, but I see a drooping? One is lack of support. You should know this. Just don't mug it up, have an idea. So lack of support can be either enophthalmos, phthisis bulbi, microphthalmos. Enophthalmos is when eyeball goes inside, right? Phthisis bulbi is your blind shrunk eye, and microphthalmos is again small eye. How much small? Did I teach you? Yes, I taught you. Less than 21 millimeter of axial length is called microphthalmos. Right? So enophthalmos, then phthisis bulbi, these are all for these are causes of lack of support where you can see too. Can you think of something else? When the other eye there is lid retraction, it seems this one is ptotic. Right? So contralateral lid retraction. Then if the eye is hypertropic, it can give you an impression. Only hypotropia can also be a cause. Of course, we already know about dermatochalasia, and when there is excessive skin on the eyebrows, and that is hanging out, and because of that the lid is going down, then you call it brotosis. So we should know what is brotosis and we should know what is dermatochalasia. Okay? Okay. So these are the few causes. Have you learned with me? Lack of support, contralateral, retraction, brotosis, dermatochalasia or hypertrophy. I think it's done. Huh? Okay. We next talk about eyelid tumors. What is important? First, you should be familiar with what can be the tumors possible on the eyelid. Of course, basal cell carcinoma. This is a BCC you are looking at. Number 1, note down. Second, write down. Squamous cell carcinoma, sebaceous cell carcinoma. We can get malignant melanoma and Kaposi sarcoma, which you see in HIV patients, that is Kaposi sarcoma. Okay, what are the questions around it? First question, most common malignant tumor of lid. So most common we all know is, so what is the most common malignant tumor of the lid? We will answer. Malignancy of the lid is basal cell carcinoma. Next question, most common site of BCC. Most common site of BCC, you will first say lower lid and then Next answer will be medial canthus. So first answer is always lower lid and then medial canthus. Right? Okay, second most common is squamous cell carcinoma. Talking about second most common we just read is squamous cell carcinoma. What about sebaceous cell carcinoma? Very important question. A patient who is presenting with recurrent chalazion should be suspected for this carcinoma. Why? Chalazion is a chronic lipogranulomatous inflammation of the meibomian gland. Sebaceous cell carcinoma is also arising from there. Meibomian gland is the sebaceous gland, isn't it? We'll talk about in chalazion as well. As of now, just note down this, that sebaceous cell carcinoma may sometimes present as recurrent chalazion, right? We should check for sebaceous cell, and most common site for sebaceous cell is upper lid. This much is enough when we talk about tumors at our level, what they have asked you. We next talk about is entropion. So let's give the next heading, entropion. What is entropion, all of you? Inward turning of lid margin. Note down, it is inward turning of lid margin. Now how much inward it goes, accordingly you can grade it. It's a very simple grading, that if it is the posterior lid margin which has gone inside, it is grade 1, right? If it is the intermarginal strip that is also inside, this becomes grade 2. When the intermarginal strip is also turned inwards, and if the anterior border is also turned inwards, this becomes grade 3. When the anterior border. So if you do not want to learn this, that's absolutely okay, but it was ridiculously simple grading, so I gave it to you, right? So because they haven't asked you till yet. Now we talk about is what are the types of entropion. So you can classify entropion as involutional. What is involutional? That means in old age. It can be psychiatrical. Any scarring in the conjunctiva can pull the lid inwards. That is called psychiatrical. Right? Then it could be congenital. Right? When the retractors are not formed properly, it is going inside. And fourth, it can be spastic. Due to the spasm of the muscle, it is going in. So these are the long-term patching can lead to spastic entropion. Okay, one by one we first talk about is involutional. Why do you get an entropion or inward turning of lid margin? So this is all about lower lid. This is what is needed. So involutional entropion, there can be, what are the mechanisms first of all? There can be three reasons of why it is happening. One reason is there is overriding of preseptal over pretarsal muscle. We are talking about orbicularis oculi. So when there is an overriding of preseptal part of orbicularis oculi over pretarsal. Okay, let me put the treatment also along with this. So we will first note the mechanism, that will be easy. Second I said was when the retractors are not functioning, that is disinsertion of lower lid retractors. So when there is a disinsertion of the lower lid eyelid retractors, that can be another mechanism why you are getting entropion. And third, it could be a horizontal lid laxity. Now when I say horizontal lid laxity, right? So how are we going to test the horizontal lid? How do I know this lid is horizontal, is lax or not lax, right? So this is tested by either you can go for a pinch test. When you say pinch test, you're just pulling it down and seeing how much it can be far from the eyeball. So it is either a pinch test or it could be snap test. So when you leave it back, how quickly the lid goes back, that is your snap test. So when you talk about how do you test the horizontal lid laxity, I said there are two tests. One is pinch test and one is snapback test. What is snapback test and what is pinch test? So in case of the pinch test, you are just pulling the lower lid and seeing how far it can move from the globe. So normal value is around 6 to 8 millimeters, but anything more than that is lax, it shows laxity, right? So this is one important. Second important test is once you are pulling it and you leave it, snap back. So it should snap back within a blink. Without even a blink, it should immediately go back. But if it is taking few seconds and the patient has blinked in between, then that means it is laxity. If this is also increased, that means there is a horizontal lid laxity, right? So keep this in mind. Okay, so once we know and test the horizontal lid, so these are the three mechanisms by which we can test the horizontal lid laxity, two tests, and these are the three mechanisms how entropion can happen. Okay, once we know this, we are going to now understand how do we treat it. What is the treatment? Suppose it was mechanism number 1, that is overriding of preseptal over pretarsal. So either I just give a transverse everting sutures. That can be one option. Okay, transverse everting sutures. Secondly, what I can do is, I can give a full thickness lower lid pain. I split it full thickness and then give the transverse everting sutures. So this is a transverse lid splitting first and then giving the everting sutures. Now this is what is called Weiss procedure. Right? When you talk about second mechanism is disinsertion of the retractors. You want to make it tight. So plication of lower lid retractors. In case of lower lid retractors are weak, we go for plication of lower lid retractors, and this is what is called Jones procedure. Right? So this is what is called Jones procedure. We come to the third. What was the third mechanism? Horizontal lid laxity. How do you treat a horizontal lid laxity? Now you have to, what you do if this is the lid? You cut a pentagon like this. Right? So this is how we correct a horizontal lid laxity. It's called Bick's procedure. We go for pentagon incision. Right? To shorten it so that the laxity is less. Now sometimes if there can be another thing that overriding factor is there and there is also horizontal lid laxity. If this is the case, now what I do? I will do the Weiss procedure, transverse lid splitting, and I am also going to add to this is your pentagon. Okay, so when Weiss procedure is done with the pentagon incision, this is what is called Quickert's procedure. This is what is called Quickert's procedure. Right? So keep this in mind. Now that was about your involutional entropion, right? So this is your entropion. Coming to the second type was your congenital entropion. When you talk about congenital entropion, what is the cause? Lower lid retractors are not well developed. We just mentioned that. And when lower lid retractors are not well developed, to actually tighten it, what we go for this time is your Hort's procedure. We are surgically excising some elliptical part of skin and underlying orbicularis, and later we are giving a plication or you can say we are suturing the skin with tarsal plate and as well as with the retractors. Okay. So what did we learn? We are actually joining or suturing the skin with the tarsal plate. After this, what we are doing? We're joining the skin with, we are giving a bite to skin and tarsal plate and the lower lid retractors. This is how you are going to manage a congenital, and this is what is called, just remember the term, I don't think they were going to ask you the procedure. This is what is Hort's procedure. We next talk about, after this is your psychiatrical entropion. When you say psychiatrical entropion, it means the scarring of the conjunctiva. We have just discussed the causes of scarring. It could be due to any cause, and that is leading to inward rotation of the eyelid. How to go about it? You cut the scar and you go for grafting, like mucous membrane grafting can be done, or any skin or of course you have to treat the cause as well, right? What is the next thing I can do? Because there is scarring and inward rotation, you can go for tarsal fracture. So tarsal fracture ke baad we have to put with everting sutures. Note it down, tarsal fracture with everting sutures. Or we can, and if there is a trichiasis, which is misdirection of eyelash, so if it is due to entropion, it is different. Then in that case, it is called pseudotrichiasis. But any associated misdirection of the eyelash, that is trichiasis, also should be treated. Right? So one way of also managing this is again splitting of the lid and putting an everting suture. Apart from epilation and other methods that you do for the hair, if there is any surgical treatment that we do this. So in surgical treatment, what we are doing, we are splitting at the gray line and we are repositioning the retractors. Okay, so one method can also be split at, I don't think they will ask you if you want to write, you can write down splitting at gray line, and then we are going to reposition retractors. Reposition the lower lid retractors. I think we can ignore this one. This is enough. Tarsal fracture is important, mucous membrane graft, that is enough. We come to the next one is your spastic entropion. When you say spastic entropion, it is long-term patching has caused spasm of the muscles, and therefore we go for botulinum toxin. Mainly we are doing this to relieve the spasm, so keep this in mind. Sometimes if you want to go for surgical intervention, I'll just read this for you. The displaced fibers of orbicularis oculi muscle cause the eyelash or the lower eyelid to turn inward. In that case, you have to correct it. Correct the laxity. So that can be also long-term patching is causing displacement of, there is also your displacement of orbicularis oculi. Again, what is important for you? Treat the cause of spasm and botulinum toxin. This is enough. Okay? Okay. We next talk about is, so we will, all those points which are a little bit extra, I am also pointing it out. So if you are not in a mood to learn immediately, you may ignore it. We next talk about is ectropion. So when you say ectropion, it is just the reverse, we will write down, it is the outward turning of lid margin. It is outward turning of lid margin. Right? Again, if you want to grade it, again a very, very ridiculously simple grading, you will say that punctum, when is only the punctal area is out, then it is grade 1, right? If you can see due to that, see the palpebral conjunctiva, this is your grade 2, and if you can see the fornix, so much is outward turn that we can see the fornix, now it is grade 3. Again, grading will not be asked in detail. Next we talk about is how do we classify ectropion. So how do you classify? One is your involutional, which is due to old age. We have already done that in entropion also, so you know what is involutional. Second, it can be psychiatrical. This time the scarring is on the skin, right? It can be paralytic as a part of seventh nerve palsy, which is causing outward turning, right? So it can be paralytic. And lastly, it can be mechanical. No, it's not lastly. One more I will add here. Rare but is an entity is congenital ectropion. 2-3 points, I'll start with this one only. Congenital ectropion is a rare entity. 2 syndromes where we will learn it. One we have already done is blepharophimosis syndrome, and second you will remember is Down syndrome. Blepharophimosis and second is your Down syndrome. Okay? Okay. Then we talk about one by one. First is involutional ectropion. So when it is involutional ectropion, one is it is happening due to horizontal lid laxity. Again, if this is the case, now of course you can go for a pentagon incision. Second, what you can see is that along with the horizontal lid laxity, there is also excessive skin. So you have to remove this, resect this also. So in this procedure, we are doing a pentagon incision, and along with the pentagon incision, we are also removing cutting the resection of excessive skin. Right? So this is what is called, you are asked sometimes, Kunt Zymanowski procedure. Okay, just remember the name. Only name is also enough. For at your level, what they've asked you, this procedure is done for which condition? Entropion or ectropion. It has been that simple. So I am talking little bit quite in detail here. So you should be able to answer all questions. Second thing that you have to learn, what can be this was one, this is second. Sometimes only the medial part, right? So if only there is a medial ectropion, only medial ectropion. If there is an only medial ectropion, then I am going to go for medial conjunctivoplasty to make it inside. What do you do in the medial conjunctivoplasty? I am cutting a diamond shape, tarsal, part of tarsal and conjunctiva. Okay, and sometimes another situation can be that along with only having a medial ectropion, okay, but you are also having horizontal lid laxity. If this is the case, now you go for medial conjunctivoplasty and you also have to go for the lid excision. You may choose to go for pentagon excision to manage the laxity as well. And this is Lazy T procedure, or the full name is Byron Smith Lazy T procedure. Byron Smith Lazy T procedure. Okay, so this was about your different procedures done for ectropion. We next talk about here is psychiatrical ectropion. Yeah, so when you're talking about psychiatrical, we know there's a scarring outside in the skin because of which there is ectropion. You can see it here. So you have to just treat the scar with Z-plasty, or you can use grafts and flaps. Right? Simple. It is happening. The scarring can happen due to any trauma or burns. This is psychiatrical. What is next? Next is your congenital ectropion. I told you is a rare condition where the lower lid retractors again are not formed as a part of blepharophimosis syndrome. We are doing here skin grafts. Coming to paralytic ectropion. Paralytic means part of facial nerve palsy. So again you have to treat accordingly to see that there is no exposure keratopathy as well. So artificial tears and ointments, and along with that this ectropion, if you can go for, is your tarsorrhaphy. You can treat with if poor Bell's phenomenon, tarsorrhaphy I told you, where we are joining the two lids to close the eye. And permanent treatment again can be medial canthoplasty, or sometimes we can use silicone rings. Okay. Just understand those numbers. We next talk about is mechanical ectropion. Mechanical ectropion, as I said, any swelling which is causing an ectropion like this. So you have to just remove the cause, right? Treat the cause, like eyelid tumors. Okay, this is a slide of epicanthus. You saw epicanthus inversus. This one is epicanthus. Now our next heading after this ectropion and entropion, let's give the heading blepharitis. Right? What is blepharitis, all of you? You will say it is not inflammation of lids. This is a common mistake. We'll say inflammation of lid margin. So blepharitis is inflammation of lid margin. Okay, so we have just read that lid margin can be anterior lid margin or posterior, isn't it? So we just made this diagram and we know that lid margin can be either anterior or posterior. What is in the anterior? Eyelashes. Posterior, meibomian glands. Opening of meibomian glands. So anterior blepharitis means there are some depositions at the base of lashes. Anterior lid margin is involved, it is anterior, and when posterior lid margin is involved, it is posterior blepharitis. Got it? So we will divide like this. It can be either anterior blepharitis or it can be posterior blepharitis. So when you say anterior, we can further divide it into two. Either it is squamous, which is also called seborrheic. Squamous or seborrheic blepharitis. This will happen in patients of seborrheic dermatitis. It is seen in patients of seborrheic dermatitis. You see the similar changes on the scalp as well. Okay, and then Second type will be ulcerative, right? Ulcerative, where there are scales below which there are ulcers. So you can note down ulcers below the scales. Ulcers below the scales. This happens due to staphylococcal. So you can also call it staphylococcal blepharitis, staphylococcal infection. And this is mainly associated with atopic dermatitis. This condition is mainly associated with atopic dermatitis. What about posterior blepharitis? Posterior blepharitis is also called mebomitis. This one is associated with acne rosacea. Okay? Now, this posterior blepharitis or mebomitis, what is happening is meibomian gland dysfunction, can lead to meibomian gland dysfunction. When you say meibomian gland dysfunction, it means the lipid is not able to express out. So the meibomian gland dysfunction, what is happening? The bacterial lipases, they are metabolizing they are forming free fatty acids. Okay? So this free fatty acid in the meibomian gland is not being able to expressed out. It is decreased expression of this lipid from the gland. Because of the decreased, so this is what is meibomian gland dysfunction, when the lipid is not being able to be expressed out properly from the gland, and when it is so, you can see those oil globules at the opening of the meibomian gland. So when lipid cannot come out, think yourself which layer of the tear film is being disturbed? Lipid layer. So when lipid expression is not possible in meibomian gland dysfunction, what will happen? That it will affect the lipid layer, and this affects the lipid layer of the tear film. And when it affects the lipid layer of tear film, this will lead to dry eye. Okay, so that causes dry eye problem as well. So this is the basic of meibomitis. Now, in all these types, anterior and posterior, if you ask the patient, he will always tell almost the common presenting features. He will talk about burning sensation in the eye. He will say grittiness in the eye. He may complain of mild photophobia. Okay. They may be, and of course, when I am looking, observing, what are the on-examination findings? On examination, I can see mild redness. If it is a squamous blepharitis, I am going to see dandruffs on the lashes. Will just show you the slide. If it is ulcerative, I will see scales below which there are ulcers. And if it is posterior blepharitis, I am going to see oil globules at the opening of the meibomian gland. Right? So, this is how these findings are. So, we call it, and this is ulcers or crusting of the lid margin. You can see the crusting of lid margin. So, according to the type, you can see these changes or findings of the blepharitis, right? So, presenting feature is mainly burning and gritty sensation, and this is what I am getting on examination. Coming back to treatment part. First, have a look at the findings. So, see, this is a squamous blepharitis with dandruff on the lids. This is showing lot of crusting and ulcerative blepharitis, and these are the oil globules that I was talking about for the lid margin, at the posterior lid margin due to meibomitis. When I talk about the treatment, so the treatment part we can divide it as how to maintain the lid hygiene, what are the medicines I am going to use, right? And of course I have to manage the dry eye. We already know how to manage the dry eye, already discussed. Now, lid hygiene generally, especially in case of squamous blepharitis or in either, we can just tell them to wash the lids daily as a routine while taking bath by diluted baby shampoo. Okay, Johnson & Johnson baby shampoo generally is asked to be bought and be diluted and keep washing your lashes. Okay, so this is important and they ask you. So wash eyelashes with diluted shampoo. Baby shampoo you have to say. Right, this is one thing. So, or you can even do it with sodium bicarbonate. whatever. And secondly, if it is a mevomitis, you may like to advise the patient for lid massage, so that the oil or the lipid is coming out of the gland. So we can go for lid massage. Of course, the massaging should be always towards the lid margin so that it expresses the lipid out. Please don't start doing it opposite. In case of posterior mevomitis or posterior blepharitis. Okay. Medicines, of course, if you talk about in squamous, if I talk about squamous, I may also give an antibiotic steroid ointment if needed. In case of ulcerative, I am only going to give antibiotic ointment. Antibiotic, which antibiotic? Generally we can go for chloramphenicol or we can go for fusidic acid. And in case of if it is a mevomitis, I may need to go for some oral antibiotics as well. Oral antibiotics. Either I give a course of doxycycline, I can give, right, for posterior. 100 milligrams VD, we all know this, right? This can be given for a week. This is the main treatment that you go for. Then we talk about is dry eye. Of course, I will give lubricating eye drops. I am not writing that. And a newer modality of treatment, if you needs mention here, this newer modality is mainly for your posterior blepharitis, where I can give thermal pulsations for helping to express this lipid out. Thermal pulsations. Just remember this. Okay, we come to the next condition. What is this? This has been your exam question. Okay, so be alert here. This was the slide also given to you in your exam, and they had asked you a spot diagnosis. So this is extra, if you see, there is an extra row of lashes out here. And this is what is called dystichiasis. So dystichiasis is a congenital anomaly with extra row of eyelash. Do you realize that one is on the anterior lid margin, but posterior one is going to rub on your cornea. So immediately, as an urgent basis, it should be removed. How to do that? Diathermy or cryo. We want to damage these eyelashes. The temperature of the cryo that we use is minus 20 degrees centigrade. Come to the next one is trichiasis. What is trichiasis? It is misdirection of eyelash. Okay, so misdirection of eyelash, it will rub on the cornea, again be harmful, leading to corneal ulcer and corneal opacity. So this misdirection of eyelash, write down. Now, if it is due to entropion, you call it pseudotrichiasis. Now, of course, then what can it lead to? It can cause punctate erosions or ulcers or neovascularization of the cornea. That is called PANAS. And how do we treat trichiasis? I can go for epilation, but as you know, it will again grow. Either I go for diathermy or I go for cryo at minus 20 degrees. Okay? So either diathermy or cryo. Come to the next condition. So what is madarosis? They have asked you. Madarosis can be loss of eyebrows, also is called madarosis. Loss of eyelash is also called madarosis. So sometimes people misunderstand, and students ask me, okay, when both are lost, then it is madarosis. No, we are not saying this. We are saying loss of eyebrow, you call madarosis. Loss of eyelash, again you call madarosis. Is it clear now? So it's an overlapping term for both loss of eyelash and loss of eyebrow. Loss of eyebrow, the causes mean that we will learn are the systemic causes. Please learn and write it. Don't go on what is printed there. First we will write the important things. So, leprosy and myxedema. Leprosy and myxedema. Okay. Now we talk about is loss of eyelash. Most common cause, if they ask you, is chronic blepharitis. Now once you know these important points, so this is loss of eyelash. I can't see an eyelash here. Here it is missing. Here it is missing. Right? So it is less dense, isn't it? Again, this area, I think there is no eyelash. So this is what is madarosis. We said loss of eyelash and eyebrows, both are madarosis. Causes of eyebrows, losses, leprosy, myxedema, and most common cause of eyelash loss, we will answer chronic blepharitis. Other causes could be tumor, burns, then some skin disease like psoriasis. It can be also by one more point. What is trichotillomania? So you all know where there is mainly a psychological condition where the patient is keep pulling his eyelashes. That is called trichotillomania. That is also going to lead to your madarosis. We next talk about, this is also exam question, what is scoliosis? Scoliosis you have learned with me in both Koyanagi-Harada syndrome and Waardenburg syndrome. So scoliosis is graying of eyelashes. As you can see here, graying of eyelashes is called scoliosis. It can also be a part of chronic blepharitis as a complication of chronic blepharitis. This is a case of albinism where you can see scoliosis and also graying of the eyes. Yes, depigmentation. Right? Then what is this? So this is again exam question. Tylosis is nothing but thickening of lid margin. Okay? So thickening of lid margin. Again it is due to chronic blepharitis. It is due to chronic blepharitis. Next is, what is symblephron? Symblephron is adhesion of the bulbar with the palpebral conjunctiva. Write down. Adhesion of bulbar and palpebral conjunctiva. Okay? So when you look here, what can be the causes? Of course, scarring is happening due to burns, chemical injuries, surgery, or any ulcer. Right? And when the two lids join, what do you call that? Ankyloblepharon. Adhesion of the two lids. This one is congenitally seen here. So write down. When there is adhesion between two lids, this is called ankyloblepharon. What is ablepharon? Absence of lids. If you want to know, ablepharon will be absence of lids. We next come to this condition. Can you see and appreciate here? This is a swelling which is on the margin of the lid. Lid margin. So this is a swelling at the lid margin. What do we call this? In common term, you call it style. But what you have to know is that it is also called hordeolum externum because it is in the external anterior lid margin. At the base of the lashes, we call it hordeolum externum. Okay, make the correction, it is externum. So what is the meaning of hordeolum here? Hordeolum means swelling, right? So it is a swelling on the, I want you all to make this diagram for yourself, please. It is the swelling. Is it a painful swelling or painless? It's a painful swelling. Let us put it in red. At the anterior lid margin. This is the anterior lid margin. So it is a painful swelling on the anterior lid margin. Please note it like this so that you never forget. It is also called style. Now coming to how do you manage it? We will manage it with hot fomentation. That is more than enough actually. It will resolve. If you want to, you can use oral anti-inflammatories if the pain is too much. And if needed, we can also go for antibiotic ointment at the swelling. Generally not needed. These two modalities will help and it will be resolve. It will resolve, right? Achha. What is hordeolum internum? We make another diagram. Can you see this time it is on the tarsal plate? So let us write like this. Any swelling, make the diagram so that again you don't forget. Many of you say hordeolum internum is chalazion. A common mistake, it is not. What is the difference? It is acute inflammation with a painful swelling is hordeolum. Acute inflammation of what? Meibomian gland. So hordeolum again is swelling. Internum means on the tarsal plate, on the lid this time. And now note down, this is acute inflammation of Meibomian glands. Right? So hordeolum internum will be very painful condition. Tarsal tissue is already very dense now. So any swelling there is very painful. How do you manage it? Apart from hot fermentation, I go for, this time I may need oral antibiotics as well and oral anti-inflammatories. Oral antibiotics, oral anti-inflammatories. We next talk about is, what is chalazion? On the same diagram I am putting, this time it's a painless swelling on the lid mask. So the painless swelling on the lid, not margin, lid, on the tarsal plate. This painless swelling is chalazion. Repeated question, what is chalazion? So how do you define chalazion? They have asked you repeatedly. We learn chalazion is, make two cues, lipogranulomatous inflammation of meibomian gland. It's a lipogranulomatous inflammation of meibomian glands. Okay, and it will present as painless swelling on the lid. This we have already done. How do you manage this? Number one, incision and curettage. Don't say drainage because it's organized secretions. So curettage. It's not a liquid pus. Even this was asked in the exam. Incision, drainage, or incision, curettage. Secondly, whenever you are giving an incision and taking out in a chalazion with a chalazion clamp, put the clamp. Very, very important point, all of you. It should always be a vertical incision. Why? Because the ducts of the meibomian glands are all vertical. So if I put horizontal incision, in that case, we will damage the ducts. So we go for vertical incision. And second modality can be, I put an intralesional injection, means inside the lesion, injection of TA. What is TA here? Triamcinolone acetonide. Triamcinolone acetonide. Right? So, okay, one more question here. This is what they've asked you. You have a patient with recurrent chalazion. What is the most common cause? Don't say sebaceous cell. Most common cause of recurrent chalazion. You will answer. So what happens is, any patient with a very mild refractive error, he is not using specs. Chodo mera kaam chal raha hai. So if he is not using specs, he doesn't realize, but every time he has to clear his image, he is rubbing his eyes. More frequently, he is touching his eyes, he is getting inflammations again and again. So the most common cause of recurrent chalazion is uncorrected, means you are not wearing specs, mild, then only you can manage not wearing specs when it's a mild error. So uncorrected, mild refractive error. If I have to think of any other cause, yes, then we have to also check for sebaceous cell carcinoma. Very sorry. Sebaceous cell carcinoma. So otherwise, the next you have to check for sebaceous cell carcinoma. What did we learn? Sebaceous cell carcinoma, most common site is upper lid. So these are some simple information. So uncorrected mild refractive error should not be forgotten. So it happens. So I have faced many times. OPD, the patient is coming and he has come for this problem of swelling, which he says that it happens again and again. And I want to test his refraction. I want to do refraction and I want to give him specs if needed. He is very unhappy with me. I don't want to wear specs. Why are you asking me to wear specs? Treat my swelling. So please remember, this is one of the very common causes of recurrent chalazion. Okay? Yes. So I think we have covered almost all questions from the lids. So that was all about the lids. Hope you enjoyed the chapter. Thank you so much. Stay blessed and keep smiling.